Dr. Sanjeev Levin. He has done MBBS, MD, and DNB. He's a professor of family medicine, pediatrics, medical education, and clinical ethics, former chief of medical services, St. John's Medical College Hospital. He is the adjunct faculty, clinical professor, medicine, CIHEB Center for International Health Education and Biosecurity, IHV Institute of Human Virology, University of Maryland's School of Medicine, Baltimore, MD, USA. He has received multiple awards and he has multiple national and international publications. His areas of interest are medical education, disaster preparedness, HIV care, and treatment. Brigadier Rajiv Kumar Saini. He has done MBBS, MD Psychiatry in 2001 from AFMC Pune, Maharashtra, India. He is Professor Psychiatry at AFMC Pune and Command Hospital, Kolkata, India. He has received Colonel Kripal Singh Award for Best Paper, Annual National Psychiatry Conference, and he is the Chief of Army Staff Commendation 2011. He has 35 publications in national and international PubMed indexed journals. He has keen interest in stress management for troops deployed in counterinsurgency operations, brain stimulation techniques. I would like to call Dr. Sanjeev Levin to introduce his speakers. Like there are slides for.
Okay.
Yes, sir.
So good morning. Happy to introduce our first speaker, Dr. Vikas Menon. Dr. Vikas Menon is an MBBS, MD, and DNB, and the professor of Department of Psychiatry at JIPMER, Pondicherry. Important to know is that he's a core faculty member of the NTTC, which is the National Teachers Training Center at JIPMER, which has taught many of us for many years, ever since I think the late 1970s. He's also a core faculty member of the Indian Teachers of Psychiatry, Scholarship for Teachers to Enrich Psychiatry Teaching Skills, that program since its inception. He was on an expert group which worked on the EPAs, which are Entrustable Professional Activities, for revising the PG curriculum of the Indian Psychiatric Society. He's also the deputy editor of the Indian Journal of Psychiatry. Interests are suicide, mood disturbance, disorders, digital psychiatry, and medical education. Ladies and gentlemen, Vikas Menon. Do you want to start now? Okay. Okay, sorry. So I'm going to introduce Dr. Abhijit Bandita, who is an MBBS MD from AIIMS, New Delhi. Presently the senior resident in psychiatry in JIPMER, Pondicherry, and in her previous position as senior resident in AIIMS, Bhubaneswar, did a lot of work on EPAs. She presently has over 10 publications, and happy to have with us Dr. Abhijita Bandita.
Good morning. First of all, thank you to the chairpersons for the kind introduction. Thank you to the organizers of this event for having us here. And thank you to all of you on a Sunday morning for taking time out to come here. So this is a new area perhaps for many of us, and therefore feel free to give your input as we are going along. So the topic is trust in training, unlocking competence with entrustable professional activities in psychiatry, and myself and Dr. Bandita will be taking this session. So this is how we propose to structure this session. We'll have a brief introduction to EPAs for at least some of us may be uninitiated. So we'll go through the definition, the important attributes, the purpose of having EPAs, and what are some of the advantages. And then Dr. Bandita will take a session on EPS for undergraduates, how to frame, giving examples of EPS along with their corresponding milestones and evaluation, and I'll do the same for postgraduates. And then we'll end with a look at some of the challenges in implementation, and then we can have some Q&A at the end. So before I start, I have no conflicts of interest, but as the chairperson was mentioning, I was part of the working group constituted by IPS for framing EPS for postgraduate training. Actually, Dr. Kaushik should have been here to do this session, but I believe he could not be here because of some scheduling conflicts. So therefore, I'm taking this session. So what is an entrustable professional activity? So it is a unit of professional practice that can be fully entrusted to a trainee once he or she has demonstrated the necessary competence to execute this activity unsupervised. So I have highlighted some of the key elements there in red, and let's go through each of that. So a unit, here what does unit mean? A unit means it's a discrete professional task. Say for example, managing a patient with acute delirium tremens. Or it could be a bundle of tasks, like say for example, stabilizing a patient of acute stroke. So there you have several component pathways. You have to do a neurological examination, you have to do a swallow screen, you have to think about thrombolysis, you have to think about brain scans. So many tasks are involved there. So it could be a single professional task or a bundle of, like a care bundle. And fully entrusted. So what does entrusted mean? It means that the trainee meets certain minimum standards that is required in order to perform that activity unsupervised. Fully entrusted means no level of supervision is required. But it could have various degrees, as we'll see. There could be various degrees. There could be something that you want your trainee to do under partial supervision. You don't want him or her to do that under no supervision. So you could decide, as the faculty, you could decide under what level of supervision you want the trainee to do that particular EPA. But whatever it is, this is the definition and some of the important components. The rest of it is fairly self-explanatory. So we'll go through some of the attributes of EPAs. It has a clearly defined beginning and end, both in terms of the activity as well as in terms of the time frame in which it is supposed to be achieved. For example, this EPA is supposed to be achieved in the first professional year or second professional year or whatever it is. And beginning and end in terms of the activity means like you will have certain steps that I just now mentioned. For example, in stroke, what is the first thing you do and last thing you do. So there is a clearly defined beginning and end of the EPA. It is independently executable. That is a bit of a no-brainer because you are going to give an entrustment decision at the end. So the trainee should be able to independently execute it. That's how you make an entrustment decision at the end of the EPA. It is specific and focused. Specific in terms of, first, the steps that are required to be done. Specific in terms of the setting where it is to be done. For example, is this EPA supposed to be performed in the emergency setting, or is it supposed to be performed in the outpatient setting? And specific in terms of the context, is it in a learning, is it in a clinical care context, or is it in some other context? So what is the context, what is the setting, and what are the steps? So it is specific in all these aspects. It refers to an observable skill or behavior that you can observe, either bedside or in the outpatient department, and it's therefore measurable. This is very important. It should reflect work that is directly relevant to patient care. So it is, it should represent a legitimate contribution to healthcare. For example, that immediately now tells you that something like preparing a teaching schedule, that cannot be an EPA because that is not directly relevant to patient care. You are preparing your logbook or your CV. That is not a EPA. That is at a personal development you are doing it, but it should be directly relevant to patient care. Integrates multiple domains of competence. This will be clear as we go through the individual examples of EPA, but just to give you a flavor, even when we say an EPA could be something like conduct a psychiatric assessment of an uncomplicated mental disorder. So you have to obtain consent for the interview, you have to demonstrate empathy, you have to conduct an MSc, you have to interpret a mental status examination. So many competencies are bunched together in an entrustable professional activity. And So EPA describes a task, and you have to avoid adjectives. For example, some people may want to frame an EPA like this: skillfully demonstrates, skillfully assesses, conducts psychiatric assessment. That kind of an adjective is redundant actually in an EPA, because it is understood you don't want the person to unskillfully do it, no? So you don't need to add these kind of redundant adjectives: skillfully, adequately, carefully. All these things are not required. You can avoid all that and just go to the EPA. So avoid redundant adjectives when referring to proficiency. So what is the purpose of EPAs? So I want to put that question in a different form. What do you think is the end goal of graduate medical education? If we can answer that, perhaps we would get the answer to the purpose of EPAs. What is the end goal of graduate medical education? Lifelong learner. Any other thoughts? As a teacher, what do you want them to do? You want them to research, okay? You want them to take care of a patient competently. So there lies the utility of EPAs. You want them to be practice ready, isn't it? You are certifying them and you are sending them out. Now they have to be ready to do certain things. Are they ready? In a traditional time-based curriculum model, are they ready? So that was one of the, one of the drawbacks that why we moved to CBME. Because in a traditional time-based curriculum model, we were never sure whether they are actually achieving all the competencies. So that's why we moved to CBME. Now in CBME, there came this drawback that, okay, they are able to have some of the competencies, but are they able to integrate all these competencies in order to effectively manage a patient? For example, they are able to read an ECG. That is a competency. But are they able to read an ECG and use that knowledge in order to plan thrombolytic therapy for a patient with acute myocardial infarction? That is the question. So that is, are they able to integrate that? So this is where EPAs come in, because an EPA would be actually managing a patient with acute myocardial infarction, not just reading an ECG. So it serves actually, EPAs serve to bridge theory and practice. It helps translate competencies into practice, because you have reading an ECG as a competency, but that's not sufficient for that person to manage. So you want to actually bunch those into what is a relevant EPA and make them practice ready. So that is the entire vision of EPAs, that you entrust them with a certain amount of entrustment decision is made so that they are practice ready. It helps supervisors make decisions, because you're going to entrust, you're going to observe, and you're going to make entrustment decisions. So now you are also more confident as a supervisor, because you know that yes, this person is able to do this activity under certain level of supervision or no supervision at all. And from a learner perspective also, it creates better learning opportunities, more feedback opportunities, more engagement opportunities for learners. So what are the advantages of EPAs? This is the last slide before I hand over to Dr. Bandita. So greater trust and confidence in the trainee's ability. You understand, no? Now we have observed it as an EPA. So we as a supervisor have greater confidence that this person can now go back and apply it. You agree with me? Improved patient safety, because you have observed them in something like a real world situation and then certified or entrusted, with the, you have really been convinced with their skills on how to do it. So that is likely to translate into improved patient safety. Increase clinical engagement, because you are going to bunch many competencies together, so you might want them to do it several times, so there is more opportunities for increased clinical engagement and feedback. So feedback, why? Because that will become clear as we go along. Most of the assessment methods for EPAs are workplace based assessment methods in which feedback is a very key component. So all that leads to increased clinical engagement. EPAs, why the IPS decided to form a working group to frame EPAs for postgraduate curriculum is again because they identified certain gaps in the curriculum. So it's an opportunity for us to identify certain gaps in the curriculum and formulate EPAs to address those gaps. It helps the learner, again, just like how building on what I said, to transition from practice to practice from training. And it is less resource intensive. Why? I just want you to think of this for a moment. Why are EPAs much less resource intensive than, say, for example, assessment of competencies? Yes, Varun, you want to say something? Why EPAs are less resource intensive from a teacher perspective for assessment? Saves a lot of time in planning. Anything else? I just now told you many competencies are bunched together into an EPS. Is it easier to assess 117 competencies, or is it easier to assess 10 competencies which integrate these 50 or 60 competencies? So you have one EPA which addresses several competencies. So it is more, resource efficient for you to have assess 4 or 5 EPAs than assessing 30 or 40 competencies. You agree with me? Fine. So I'll stop here on that note and hand it over to Dr. Bandita to take it for undergraduates.
Thank you, sir. I think sir has greatly described, taken us through what is EPA, what are the various advantages, what is the need, and why are we talking about in today's session. So without wasting time, I will quickly go into my topic, which is undergraduate EPS in undergraduate psychiatry. So before going to my topic per se, as we all know, the National Medical Commission introduced the competence-based medical education in 2019 first. So initially it was proposed to have 117 competencies. So it is very huge, right? And it is very, I think, will be difficult to achieve. So subsequently it has been revised, and the most recent edition, that is came in around September 2024, it has been reduced to around 13 topics and 17 competencies. Now, NMC has also made some changes in the UG psychiatry training. Right from, they have increased the teaching hours. So the lectures have been increased to around 40 hours, and the psychiatry posting has been changed from, initially it was 4 weeks, now it is increased to 6 weeks, which is divided over 2 years, that is in part 1 of third year and part 2 of third year. However, the psychiatry exams is still under general medicine, wherein 25% questions come from psychiatry. Now coming to EPS, sir has already described why do we need the EPS. When we talk about competencies, if you go through what as NMC has proposed, it divides competencies into various domains of knowledge, skills and attitudes. For example, describe signs and symptoms of psychosexual disorders, or describe IDD. So and various and now this EPS, now what will I do if I just know what are the signs and symptoms of psychosexual disorders? I will want the student to also describe, also diagnose and also treat. So EPA is a combination of all these knowledge, skills and attitudes, that is various competencies together, which is more objective and also more accessible to assessment than the competencies. So initially it was used for specialist training, like mostly for postgraduate training. Now it is increasingly used mainly at the international level at UG, in the UG psychiatry training. But in India, in last few years, research has been done in the undergraduate psychiatry. And there is a lack of standardized structure yet to document various EPS and the various milestones. So whatever in the next few slides I will be talking about is will be the extrapolation of what is the evidence from the international level, whatever the research has been done. So I will take you through a few examples, that is of EPS, which has been done and published under undergraduate psychiatry training. One of the example is, first is trainees would be able to gather a history and perform a physical or mental examination. Now I have written it as first clinical posting. So, but it is not well defined in which year. Like for example, in PG, it is defined in first year PGs would be able to do what, and finally PGs would be able to do what. But in case of undergraduates, it is not well defined. But seeing at the EPA, mostly it will be fitting into the first clinical posting, that is when they are coming for the first time to psychiatry in the third professional year, part 1. So now to attend this EPA, what will be the milestones? So it might be to present psychiatric history in a prescribed format, whatever is there according to institutes, and able to perform general physical examination and able to perform a mental status examination. Now when I talk about these milestones, it also includes a few other milestones, that is like take consent, build doctor-patient relationship, rapport building, all this there, and all these things are there, and these 2-3 EPS will be common in all the EPS mostly, so I have not included that. Now to assess these milestones, how can we assess? It might be self-assessment, or it might be a OSCE-based assessment, or it might be a workplace-based assessment or EPA performance, which I will be talking in the next slides. So now if we go to this like a little higher level, in let's say in the second clinical posting, what should be an undergraduate able to do? So it has been proposed that trainees should be able to do prioritize a differential diagnosis following a clinical encounter. Now they have not defined what all clinical encounters should an undergraduate will be able to do. So and how many should be done? Like to achieve this particular EPA, what will be the milestones? It might be the trainee can compare the various diagnostic criteria across. So at least that is a knowledge domain. The diagnostic criteria of various major psychiatric disorders, then compare and contrast, generate a differential diagnosis, and finally reach a provisional diagnosis. Now to assess this, we can give some assessment forms. We can do a pre-post test. Like before the training started, we can give certain amount of questions. It might be MCQ or it might be open-ended question, and post we can assess and see the change. Or it can be in OSCE, or it can be given in written examination, etc. Now, when I talk about this, this is a particular systematic review which has seen across various countries of US, Canada, Germany. They have various countries have worked under various EPS, and the number range varies from 8 to 13 EPS in undergraduate psychiatry. These are the most common across all the studies, so I have taken these 5 apart from the previous 2 which I told. These are like recommend and interpret common diagnostic and screening tests, enter the doctor's orders, generate a prescription, document the clinical encounter in the patient record, recognize the patient like a psychiatric emergency and refer the patient, obtain informed consent for the tests and procedures. I hope I'm clear till now. Now we will go to the various assessment methods. Now when we talk about the assessment methods, it can be like done by observing, it can be done by face to face by talking to the student, or it can be by the record. We can see the records and do some assessment, right? So when we talk about the assessment, the most common and most commonly used across is the mini clinical evaluation exercise. So this is how a mini sex looks like. Below are the in the left hand side corner and below there are the 7 EPS, and the supervisor or the trainer has to rate whether, like for example, history taking process, whether the student performed below standard or it met the standard or above standard. Apart from that, it is mandatory to have a feedback, to give feedback, like what aspects were done well and what are the suggestions for improvement. So there are some other observing based assessment like direct observation of procedural skills and feedback. So as I said, assessment can be done not only by observation but also by some case based discussions. We can chat, stimulated recall, and some entrustment based discussions, which I will be talking later, and by reviewing the results, like whether the entries in the E record was done properly or not, whether discharge letter was done properly or not, that we can check. Now, the work-based assessment is another most commonly used assessment form. So this is a sample which is adapted from the, actually the supervision was given by Chen et al. Originally, and that was given for the postgraduate training. And this sample which has taken is from as an adaptation from the Chen et al. Version. So below you can see the supervision scale. So initially when the student comes, the student might be interested to just observe. And when we are doing the particular EPS or we are taking the patient history, student is asked to observe. And later, after training, it is recommended that student should be going to the higher level. Higher level in the sense student can do the particular EPA as a co-activity with the trainer or supervisor. And subsequently, to the level 6, the student can do this under indirect supervision. Like he or she can ask only help when needed. Otherwise, he or she is allowed to do it independently. So the EPS are listed above, and we can rate particulars how the student performed based on this particular 6 headings. And there will be a specific feedback form which is common to common, and we can ask what are the stages of what are the things the student performed well, what are the areas of improvement and what are the next steps, any goals or actions which we can recommend for further improvement. Now, this is a quick task. This is a particular EPA. Document a clinical encounter for a patient of psychosis in the patient record. So, we will take some 1 minute and think about what are the various milestones and assessment methods you can think of to achieve this particular EPA. Yes.
We are doing the activity. An activity for, like you described, patient of moderate depressive something. 9 parts. 9 parts the EPA was defined. Can you go back to the previous slide, please? This one. So there are 1, 2, 3, 4, 5, 6, 7, 8, 9. So there are 9 parts. So accordingly, you have to do this activity for another patient who has come. Just go to the next slide.
For psychosis.
For psychosis, something like psychosis. So how many will volunteer to do this activity? Just raise your hand. Are there any volunteers to do this activity? So there is a candidate? Okay. So we'll give you 5 minutes. Okay. So
This is just to give a flavor, sir.
just
to
go
give,
back
so just 1 or 2 milestones also should be enough, just to
Okay.
give a flavor of how to
just
frame
go
it.
back those previous two slides. Like this, no? I think same module applies here as well. There's nothing great science, but only thing we have divided the activity into 9 sub-parts. So the basic principles of examination remain the same: investigation, differential diagnosis, then coming up with the firm diagnosis, then treatment methods, then collaborating with other colleagues also, how you're going to approach the case, and then building a team, and maybe finding out lacunae also, where they could have improved also. Is that right? Yeah. So can we, I think we can, would you like to contribute? Yes, just anyone with the name A. Yeah. Okay. But I think she is volunteering. Oh yeah, please. So it breaks the monotony when we see somebody else speaking, or here rather.
I think I'll first go with the milestones that we need to achieve is 1, gather a history, 2nd, perform an MSc, and then give your differential diagnosis, then plan the management, an acute management plan, whether the patient needs to be made IP or what are the immediate pharmacological measures that need to be done. So I think
Will you also like to tell some assessment methods?
for this, I think a direct observation method would be suited.
We can also, it can be, okay, it can be, direct observation will be more appropriate. It can be also like bedside if they're while taking the history, or we can see their whatever they have written, we can see that. Okay, it can be written exam also, kind of thing also, like whether they have generated the differential diagnosis accurately or not. It can be there.
We want to formulate a management
Yeah.
plan.
Yeah. Okay, thank you. So these were what this is also like kind of what ma'am already told. This is what I thought about it. So now what are the challenges we anticipate when we talk about this EPA? So like when we are talking about EPA, we are trusting the trainee to do a certain task without or under the indirect supervision. So we are taking a calculated risk here. The graduate might be very well encountered with some unfamiliar situation which he or she was not exposed during the training period, or nevertheless we are certifying him or her to carry out the activities that we might not be able to observe also. And next thing is, how long is this assessment valid? Once we are entrusting a trainee to go to that level, how long that assessment is valid and whether reassessment is necessary. So we don't have answer to that. And there are studies for the consumer, for the student's perspective. There is poor reception from the student side, like it is more cumbersome. In already their hectic schedule, we have to go through all this training and all this thing. There are poor reception from the student side. So these are the few challenges, particularly in the undergraduate psychiatry training. Okay. With this, I will end my session. I will ask Dr. Vikas Menon to take over the postgraduate psychiatry.
Yeah, we'll just have a look at, we already had a look now at undergraduate some EPS. Now we'll just look at postgraduate EPS before we close. No, not this one. It's the other one, continuation of the other. So thank you to the volunteer who has participated in the activity. Actually, that has kind of set the ball rolling for us to think in terms of how to structure EPAs for the postgraduate. I'm sure it will become a little easier now. So, you know, this is an EPA, and I would like you to also now brainstorm about the corresponding milestones for this particular EPA. So this is EPA for a first year resident, developing and executing management plans for uncomplicated mental illness. First of all, do you agree with me that this is something that at least needs to be done, if not fully without supervision, at least under some partial degree of supervision? Do we expect a first year, at the end of first year, that they will be able to at least develop a management plan for a patient with uncomplicated mental illness? Yes or no? Can I have a louder yes if that is the case? Yes. Wonderful, wonderful. So, if we are all in agreement, then I think I want your assistance in order to tell me what could be the milestones for this. And then I will try to show some of the milestones that I have thought about. Anyone? Yes? Case history. So taking a case history. Anyone else? Excellent. Developing rapport. Okay. Developing rapport, gathering history, developing rapport. We can put these into a particular order later. First, I think the exercise is just we need to come up with as many milestones as possible. Anything else? Using rating scales properly. Excellent, excellent. Anything else? Sorry? Risk assessment. Okay, risk assessment in relevant cases, for example, in suicide or aggression. Okay, wonderful. So, we are getting a flavor, no, how to think about milestones for a particular interest. That's the objective of this activity. Now you see here, many of what I have written are overlapping with what you have said. Select the investigation. Again, this is not an exhaustive list. This is just an indicative list. As I said, the objective is just to jog our thinking. So select investigations, rating scales, interpret the results, recognize common comorbidities, evaluate and treat appropriately, and initiating psychotropic medications. These are all, you can further break them, you know, you can further try to have more milestones based on this. Now here we say milestones, you know, this is, what is the difference between a milestone and a competency? Any thoughts on that? What is the difference between a milestone and a competency? Very good. Milestones are along the developmental continuum to achieve the competencies. So it is something like, you know, if you want to use an analogy from cricket, it's something like a T20 versus ODI versus test match, you know. So which is T20? Milestones. The ODIs, which are now going into redundancy kind of, is like competencies. And the test match, which is actually the real test, you know, they say, so it's like EPS. It's like, you know, actually making sure that the person is practice ready. So this is some milestones. And what are some assessment methods then for this EPA? What are some assessment methods you can have for this EPA? Log books, okay, okay. But then remember that this is like something, EPAs are always based on mostly observation in real time. You want to have a real time observation of what the learner is doing because you want to make an entrustment decision. you are going to say that this person is able to do this activity without supervision. So would a logbook be necessarily the best method for that? Okay, so anything else? But nice point for consideration. DOPS, okay, DOPS. Madam, you were saying something? Yes? Skill assessment. Okay, skills assessment, okay. So again, you know, think about,
Even
yes, Dr. Christina.
records, the residence records, review of the records as
Okay, 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 yeah. So that is also possible, but just keep in mind one principle, that always it is better to have EPA assessment by observation in real time. And what are those tools? Mini CEX. So workplace based assessment methods. Think about this word, workplace based assessment methods. Those are the recommended methods for assessing entrustable professional activities. And you have several types of workplace-based assessment methods. That's a whole session in itself. We will not get into that. But some of them are things like what Madam was referring to, the mini CEX. It's called mini clinical evaluation exercise, mini CEX. Okay? And then I'll show you a mini CEX form after this, so it will become clear to you. Then there is something called a clinical encounter card, which is almost similar to a mini CEX, but you will have all the components and then you will rate as unsatisfactory, satisfactory. So these are all minor variations. You could have something like a case-based discussion, which is also a very interactive form of assessment. You could have for certain milestones, like say for example, you want them to recognize common medical and surgical comorbidities. So you could have a case narrative which has these components built in. And then you could have a kind of a discussion with the learner to see how accurately and how comprehensively the learner is recognizing those comorbidities. Is this fairly okay? Are you all with me? Yes? Can I have a louder yes? Yes. Wonderful. So this is EPA 2. Now just get thinking about this EPA. This is for second professional year. Conducting a clinical evaluation and providing differential diagnosis for psychiatric emergencies. Do we agree that this is something that a JR2 is supposed to do at the end of second year? Okay, wonderful. So what are some milestones that can come into this? Just break the EPA into smallest unit, then you have your milestones. The steps, more granular. Yes. They have to have a rapport. They have to take a detailed history. If adequate history is not forthcoming from the patient, you might want to have a session with the attender. Even otherwise, you might want to have, okay. Anything else, Dr. Aishwarya? Mental status examination.
Ensure safety.
Yes, you said risk assessment. I'm very happy. Risk assessment. Somebody was saying something here? Yes? I don't know.
Ability to ensure safety during
Dr. Christina, I'm sorry. Yeah.
Yeah, safety during evaluation process.
Absolutely, absolutely. So, wonderful. So these are all some of the milestones that you might need to think about. Ability to assess risk factors for violence, suicide, self-harm, ability to reach a provisional diagnosis logically and entertain differential diagnosis, ability to conduct risk assessment, set goals for safe treatment, as Madam was saying, with the patient and treating team, ability to conduct crisis intervention, ability to recognize indications. So these are all some of the potential milestones there. What are some of the assessment methods you can use here? Again, there would be some overlap. Think about what we did previously. What are some of the assessment methods here? Again, you could have case-based discussions, the mini CEX, okay? And there's something called clinical work sampling. Have you heard of this term, clinical work sampling? This is again not rocket science. This is again a workplace-based assessment tool where you have multiple, the multiple observers actually rating a trainee in real time about their performance. Okay, so these are some of the EPAs and their corresponding assessment methods. Finally, EPAs for JR3, again conducting electroconvulsive therapy. So again, you can think about it, the principles are the same, how we again want to break them into smaller units of professional competence and milestones. So these are all some of the things. I think you can take a few seconds to go through it and let me know if you have any comments on this. Of course, you might want to add on, as I said, the aim is not to give an exhaustive list of milestones, but just to get us thinking about it. So you agree with me, these are all important milestones when we want somebody, and definitely we want a JR3 to conduct at least an unmodified ECT independently at the end of the training. Yes? Yes, okay. So what are some of the assessment methods? So again, we'll keep going back to workplace-based assessment methods. No, you can think about, see for example, ability to assess the indications and contraindications. For that, maybe you could have a written passage. You could have a written passage and ask them to say whether the case narrative that has been given to them is suitable for posting for ECT, or is there a contraindication for ECT. So you could have assessment methods depending on your milestones also. For certain things like ability to perform ECT or ability to monitor the patient, you would have to have a real-time observation. But if it is only for the first milestone, ability to assess the indications and contraindications, if that is your main aim, then you might want to have a written narrative, and then based on that you could have a discussion also. So you could have some flexibility here to choose your assessment methods depending on what are your milestones like. But generally, when you're looking at an EPA globally, it's always better to have a workplace-based assessment method. I hope this much we are all together. Now I'll just have some closing slides. So these are some logbook formats for maintaining an EPA. So it will basically have what is the EPA there and what is the entrustment decision that you have made at the end of your training. What are these levels? I'll just show in the next slide. So as you go from level 1 to level 5, the degree of supervision that you would want is going to reduce. Ultimately 5 means that you would actually entrust the learner, because the learner is so competent, that to provide kind of training to others, and what are the aspects to improve, and any other feedback. So remember, workplace-based assessment method, feedback is a very important component of any WPBA. So that forms a very important component of any WPBA. So this is the other parts of the logbook. So you have all this basic identifying details, and as I said, this is the description of level 1 to level 5. So you can do with direct supervision. Level 1 is basically, they are only supposed to do under supervision. Level 2 is basically proactive. That is, the supervisor is there nearby, and if any issues arise, then they will step in. Level 3 is, the supervisor is there nearby, but unless the trainee approaches, the supervisor may not intervene. So it progressively indicates decreasing levels of supervision. Level 4 is basically can do without supervision, and then complete the activity and come and tell their report to the evaluator post hoc. And level 5, the learner is so skilled in performing that EPA that the learner can actually provide supervision to other trainees who want to get trained in that particular EPA. So this is about the logbook format. And then, I just want you to take a moment to think about some of the challenges with in implementing EPS. And I'm sure you have plenty of thoughts on that right now as we are going ahead with the session. Any quick 1 or 2 thoughts on challenges in implementing the EPAs? Yeah, that for the EPA themselves. Can you make your question a little more clear? What do you mean by EPAs themselves? So there are 2 things here. I just want to know what you are having in mind so that I can try to give a more focused answer. Are you talking about whether the EPA itself is framed properly and the EPAs are in alignment with the literature standards or recommended standards? Is that what you're looking at, or is the trainee doing the EPA? You framed the EPA, the EPA is being done by the trainee, and whether the trainee is doing the EPA properly. You understand? So which one is? No, trainee doesn't frame EPA. EPAs are framed by the trainer. The faculty frames the EPAs. So that's how it starts. Excellent. So I get your question. So the question is whether the EPAs are framed properly and they are in alignment with recommend. So that I could not show here, but there is a rubric for that. It's called Equal rubric. This was published in Academic Medicine in 2017. So you can look up the paper. Because of paucity of time, I have not gone into that aspect. So there are rubrics which tell you whether the EPAs are framed properly. I also don't remember the exact components, but you can refer the paper for more information. It's called Equal, EQUAL. Okay. what was the question? Yeah, challenges. Any challenges in, yes. Any one challenge you can tell so that others also get chances.
So I think one challenge is that many of us who are teaching, at least for this generation of trainees, are not haven't experienced.
Are not mentally tuned because we haven't come through
the
the system.
Yeah,
Yes,
that's
absolutely.
not how we were trained.
Yes.
So
It's just like online learning, you know, we were not exposed to too much of online teaching learning, but then we have embraced online learning, you know, because of the necessity during the pandemic. So, absolutely, I agree with Dr. Rachna. I absolutely agree with what Dr. Rachna has said. Any other thought, one more thought, quick thought on challenges? I'm sure you are all bursting with challenges. What are they?
It
Need for multiple assessment methods. Okay.
along the same lines, it involves
Yes.
it involves much more work, so there would be inertia from our
Okay.
part.
I just want to give a different take on that because yes, it is initially little bit greater work to frame the EPS but then over the running cost, you know, will kind of balance it. Because you are bunching several competencies into one EPS, it's actually more resource efficient. But yes, like in any other initiative, initially there may be a little bit of planning and time involved. Any other thoughts? Yes, sir.
Sometimes the student may not have mastered the earlier EPS versus the later ones.
Absolutely. That's a very interesting thought, sir. Yes. So, unless the learner has mastered some of the earlier EPAs in the hierarchy, some of the related things may just get carried over to the EPAs that we are framing later. So, that's an interesting thought. Yes. So, these are some of the challenges, and I'll close with this. So, attitudinal barriers, as Dr. Rachna was saying, you know, there might be attitudinal barriers because we were never exposed to it, and then this is something new, and always there is some inherent opposition to trying something new. Workload concerns, as mentioned by Dr. Christina, it may take some more time for you to frame EPS initially and get the ball rolling, but then I guess over a period of time, you know, it will balance out. Some of the faculty themselves may require some training in how to assess EPAs because, as I said, this is a new area. And if you have a very large number of EPAs, that's going to be a kind of a deterrent to people to kind of implement it. So you must look at an optimal balance of how many EPAs you can have in order to assess them. So by the way, this is not a new thing, you know, many in Canada and in many countries in the Sweden and other Scandinavian European countries, EPAs are already being used for assessment. So we could perhaps look at their models and try and see how we can adapt that. And also the challenge is how to integrate EPS into existing curriculum. So that's where I think the IPS document is also currently stuck. So we prepared a report and gave it to the IPS, and I think you know, we've not been able to get moving with that because there's a challenge of how to integrate EPS into the existing curriculum. These are perhaps things that we need to brainstorm about for another day. Okay, so I'll stop here. We have taken some messages that EPS is a discrete professional task that is directly relevant to patient care and can be fully entrusted to a trainee. And the idea of an EPS is to get the learners practice ready and bridge the gap between training and practice. Can it coexist with CBME? Perhaps yes. I think so, but we need to find what is the optimal way, how it can be integrated into the CBME curriculum. Workplace-based assessment methods are probably the recommended methods to assess EPAs, and it offers some opportunities to identify some gaps and develop the curriculum so that it is more learner-friendly and supports practice. So with these concluding thoughts, I will hand over back to the organizers.
Thank you, Dr. Vikas. I think you'll all agree that he has done a wonderful job in giving a broad overview of entrustable professional activities. So there are a few questions from the audience. I think most of the questions you have already covered in your lacunae which are there, which exist, or challenges rather. But I think are these professional activities more user-friendly or more implementable in institute of national importance? Because the resources may not be that sufficient in majority of the colleges in India, which are in peripheral rural areas, government medical colleges.
I have a different take on that, sir. So we often think that way, but I am part of the National Teacher Training Center at JIPMA for many years now, and I'm amazed when I get participants from other medical colleges all over India, especially some of the private, less resourced medical colleges. They're doing such wonderful work in terms of implementing ATCOM, assessing ATCOM skills, having a very structured program for many of the things that we would think are very resource intensive. So I think it's a little bit of a misconception also that INIs are better place to implement this, and I would say that
can ITOPS be the bridging agency in ensuring that EPS?
I think ITOPS can play a potentially leadership role in this.
It is actually
in this
bringing
regard.
all the teachers together,
Yes.
especially for psychiatry.
Maybe have exclusive session devoted to EPS as the theme in a particular workshop to get this, more popularized.
So in our activities, ITOP activities, we can start including 1 capsules per session.
Absolutely, absolutely.
So that is one thing, great. Is time a constraint for most of the colleges are struggling with the faculty position. As such, I think, is time a constraint or resource, manpower resource a constraint according to you?
So, sir, as I said, initially, it might require a buy-in from the faculty side, and that also, I was seeing some questions there, how to motivate some of the faculty. So I think there is, but that is not something specific to EPS.
So can we use JR3s as?
Yes.
You
could have some of the peer assessors also.
That is something, one area which is largely unattended. We don't use our residents for training of the junior staff. You
could have senior residents as assessors, you could have other peer assessors. So we can look at, and in many of these, there is something called multi-source feedback also. So you could have observation and inputs coming in from nurses, peers and other people who are part of the system. Yes.
Okay, great.
Can I have 1 minute if you don't mind? So I found it very interesting, and let me be clear that in my experience, I think psychiatry has always been quite high on the list of education. At least in St. John's, the psychiatry department has always been very proactive in what they do. I just have a few things to say in general. So if you draw a circle and you draw smaller 2-3 circles in that circle, and you draw some stars in the inside circle, the big circle is EPA, is the role, the professional role. And the professional role has EPAs, which are the smaller circles. And inside the smaller circles are competencies. And in those small square competencies, you have specific learning objectives. So I think that the EPA is all about competency-based education. There's no difference. You must have EPAs to be competent at the end. Second point I want to make is, I think when you're planning your EPAs, please remember the outcome, the end point of an undergraduate. An MBBS graduate, you're training to become a generalist, a physician of first contact. So keep that in mind, because if you have EPAs created by the Department of Psychiatry, we're in deep trouble. So that's why the Department of Anatomy decided their competencies for NMC, and we've got over 500 competencies, which is the largest competency even though it's not even a clinical subject. So I think keep reminding yourself. For example, I do not know whether I'm right or wrong. For example, if you say an undergraduate competency is to be able to plan the treatment of psychosis or something like that, or prescribe, I'm not too sure as a generalist whether that is what my expectation is. My expectation probably is screening, identifying some, or in an emergency situation initiating and then sending to the consultant. So just remember to work backward. What is the role of this undergraduate? What is the role of the postgraduate? And go backwards in designing your EPAs. Second thing is, it is sacrilegious that the student comes to psychiatry in the first posting. The student should go through medicine, surgery, then reach psychiatry. Because there are some parts of the EPA which are already covered. So you can lessen your EPAs. History taking should be the job of the general physician in a teaching college. You should be refining certain issues. So I think that is also an important of where they come from. 3 is I do not know whether it's right or wrong, but one of the examples given was in JR2 being able to psychiatric emergencies. So I've always wondered, who takes first call in emergency? I know I'm a pediatrician and I know who was a bakra. So I'm just saying, remember that if your decision is that a JR2 should be this emergency guy, should be thorough in the emergency, then he or she should be doing the first call. But if you say that maybe the emergency has to come earlier, then the JR, I'm just saying, it may not be right what I'm saying, but third is assessment. We kept mentioning about assessment. And I think the key word, what repeatedly they try to tell us is direct observation in the practice of psychiatry. So in an undergraduate, obviously it will be the direct observation of a patient who comes with multiple psychosomatic complaints, being suspicious that something is wrong. And I think he did mention in the end 360 degrees, a fantastic tool where you say, okay, today you watch Sanjeev. He's coming to emergency. He's getting called to see a patient in an emergency, and I get evaluated by the nurse, by the patient, by the attender. It could be even a secret patient going forward. I think reflection is a very strong, and you all are very good in reflection. I think reflective writing or narration, therefore I stop using the word logbook. I think you all should go towards a portfolio and an e-portfolio. The challenge there is that the teacher has to evaluate it and give feedback. Competency-based education is all about formative. Unfortunately, in India, 3 years you have to clear. So I think the formative assessment, the feedback, using a portfolio successfully is going to be a great tool, and you all are the most likely people to actually succeed. Because as a pediatrician, as now I'm a family medicine guy, we are not good with reflection and narrative. We are very near surgeons. We're straight to the point. Last two things is, we talked about, somebody mentioned about how do you assess whether the student is achieving the milestone or ultimately achieving the EPA. So there's something called rubrics where it's very subjective. Now a senior doctor, as a senior doctor, when you're doing rounds, when a new resident joins or an undergraduate takes a history, you immediately say, this guy, you immediately realize that he's not. So senior person tends to judge by the overall performance. A junior person requires a checklist. You'll find that very categorical. So one suggestion is, it is subjective. Starting off with the rubrics is a good idea to assess key EPAs going forward. And of course, it was already mentioned, Sir mentioned, when the challenge will always be time, will be resources, and I believe mainly because we are disorganized. We are very poorly trained in our own time management, organizing our teaching, and unable to task shift. It could be to the nurse, it could be to the senior resident, it could be to a junior resident. So with that, I really thank you very much. It was an interesting thing. I think we still have miles to go, because remember, there are core EPAs which are supposed to be done through MBBS. Now, if the core EPAs are achieved, then your EPAs start at a different level. It becomes a smaller list. Because I don't want you saying it has to be history, examination, physical examination again. No, that's the job of the physician, and the student should come from general medicine to us. For example, in pediatrics, we had a group of students who came first MBBS clinical. First posting was in pediatrics. That is sacrilegious. You come in without a basic milestone being achieved. So if you have control of that, that will be a superb way to go. Of course, there's always confusion of what a EPA is, what a competency is, and I got a very simple definition which was taught to me. What you need to do to get the job done. So if I have a professional role in future, to do that job, what do I need? I'm really sorry, but the last thing is I don't use the soap in my progress notes. I teach problem-oriented records, and I think it's very useful for you all guys. You have the problem, and now I find in adult medicine, everybody's got more than one problem. So you got 6 problem: diabetes, hypertension, cardiovascular, psychosomatic, backache. The second column, I write diagnostic plan, where the student has to write, the PG or the undergraduate or intern has to write what the diagnostic plan for each of those conditions are. Therapeutic plan, what is my treatment, pharmacological, non-pharmacological plan? And third is, what is my education or counseling plan? So it's called a problem-oriented case report, a record, excellent for teaching, especially making, then you can, your assessment is you look at that sheet once a week and you say, oh, my PG is getting better. Over. Thank you very much and wonderful talk.
I think we have a task at hand to select the best question. I think somebody asked about time being the constraint. So we decided that that can be judged as the best question. So who posted this question regarding time, availability of time for the training? Yeah. So ma'am.
Get your reward for
It was an interesting session indeed. Now, thank you for the wonderful session, sir. I kindly request Dr. Christina George to felicitate the resource persons. Dr. Sanjeev Levin.
Thank you.
Brigadier Dr. Rajiv Saini. Dr. Vikas Menon. Dr. Abhijita Bandita. Thank you. Let's take a tea break for now, for 10 minutes now. It is served on the rooftop, the same place where breakfast was served. We will resume the session here at 10.